Hello, everyone. My name is Jim Seberg. I'm the Assistant Director for the Medical Cannabis Research Center at Drexel University. Today, we are happy to be joined by Dr. Codi Peterson. He is a pediatric pharmacist and cannabis science expert. He received his PharmD from Duquesne University and later graduated with an MS in Medical Cannabis Science and Therapeutics from the University of Maryland, Baltimore. Codi is the Chief Science Officer for the Cannigma, a science-forward media company dedicated to helping the world understand cannabis. He's also an associate clinical professor at UC Irvine, where he contributes to advancing medical education and will also be running a study on cannabis hyperemesis syndrome soon. Additionally, he teaches pharmacology and paramedics in Southern California through OCEMT and continues to practice pharmacy and an emergency department to this day. Codi is a co-founder of the Pharmacist Cannabis Coalition of California, which is a public benefit nonprofit dedicated to educating and elevating California pharmacists in the cannabis space. Now I'll pass it over to Dr. Peterson for his presentation for the case for balance, consumption regulation, and building for the future of cannabis.
Thank you. Appreciate you, Jim. And thank you for telling everyone who I am. I do standardly have a little slide just to explain where I'm coming from. I think it helps prime everyone. Plus, I'm happy with the photographer. So I got my PharmD from Duquesne University. I've been practicing pharmacy for about 11 years now. Time flies. And a few years ago, I graduated from the University of Maryland program to get my master's degree in cannabis science. I'm the chief science officer of the Cannigma. You guys kind of heard that. You can buy that sweatshirt if you'd like. Co-founder of the Pharmacist Cannabis Coalition of California. It's one of my biggest passions is trying to get pharmacists educated on this topic. And then that's sort of my traditional pharmacy experience. I talk a lot about the endocannabinoid system to a lot of people. Today, we're going to deviate a little bit. Now, my talk was inspired by a conversation with Jim where it just feels like we're caught in the middle of really big extremes, right? And just in general, I feel like if we look at the world and we look at the news and we look around, it's like we're either right or we're left, we're blue or we're red, we're hot or we're cold, we're black or we're white, and there's no more middle. But I think a lot of these conversations really focus in on where the middle is. So a few learning questions, as one of my mentors, Jason Wilson, inspired me to start adding. Should cannabis be a controlled substance? Right? Here we are, 2024, 53 years after prohibition started, it's still a controlled substance. And if it should be, which schedule? Is the Controlled Substance Act working to reduce harm? Now, I'm not going to have answers for you. These are learning questions, not quiz questions. So don't feel too stressed about the answer. I don't have them. But that's the beauty of being the lecturer. You kind of get to frame this. So this is a question inspired lecture, and I hope you walk away with just as many questions as you have now. But what would an equitable cannabis market look like? Would it be sort of what we have in Florida with medical only access for a restricted number of conditions, with pretty strict regulations on how much you can purchase? Or would it be kind of free flowing and there would be no restrictions and you could grow as much cannabis as you'd like and share it with your friends? And then what does medicine look like? Should a patient be able to take a drug, a medicine prescribed by a doctor in this country to them overseas? In the case of basically all prescription medications, the answer to that question is a resounding yes. But in the case of prescription cannabinoids or recommended cannabinoids, that is a no. So what medical rights does cannabis afford, and should it be similar? And then how can we learn from alcohol, tobacco, and really opium is the lesson that I'm going to try to focus in on, in the opium poppy. What can we take away from that story and take with us into this emerging field of cannabis science? So first and foremost, I'm going to put 10,000 years of history right here into this one little slide. That easy. You can see that humans found cannabis over 10,000 years ago, 12,000 years ago. We've been writing about it, consuming it, using it as medicine, using it as religious sacrament since. Asia really conquers the world along the Silk Road. It sort of becomes known all across the world, including in ancient Greek and Roman times. And then, just like much of civilization and much of knowledge during the Dark Ages, a lot was lost until the cannabis renaissance begins in the late 1800s. And there's really a drug renaissance going on at this same time as well. Scientists are really starting to tease apart what is in medicine and how can we leverage it. But not too long after the Renaissance, we get the beginning of Prohibition, which starts around the time of 1937 in the Marijuana Tax Act. You could put different dates on this timeline and make the same point. The war on drugs is really what we know as the modern version or story of cannabis criminalization, and that lasted unchallenged for 22 years until the first domino of cannabis prohibition fell, which was California legalization. Now, I need to remind you of who this wonderful man is. This is Richard Nixon, who was very interested in executing his political objectives and not very interested in the headwinds that were being created to him by the counterculture. So, in an effort to reduce those headwinds and make his political decisions easier, he decided to classify marijuana along with heroin, which was a major problem growing, and a few other drugs like LSD into Schedule 1 category, which is a high potential for abuse with no accepted medical use. And because of its designation, we have a long history of restricted access. Hopefully everyone here already knows that story, but I couldn't really tell today's story without setting up the background. Couple things I want to point out: opioids, including morphine, which is a natural opioid, is in Schedule 2. We've got fentanyl, which is a synthetic, Schedule 2. Interestingly, one of the outliers here that doesn't really line up with the other one is Schedule 1 heroin. Now, a lot of people think, oh, heroin should be Schedule 1, but I would remind you, and will remind you again in this talk later, heroin is a pharmaceutical developed by pharmaceutical companies for its benefit. What makes it more dangerous than fentanyl? Interestingly, the answer is not necessarily very much, right? In fact, there were less deaths associated with opioid abuse on the streets when heroin was rampant, and as opposed to fentanyl. So the scheduling really doesn't even make sense even for this drug heroin. One other fun fact that I learned while researching this talk: heroin, while a Schedule 1 in the United States, is not a Schedule 1 in the UK, where it continues to be used, and this might surprise you, for labor and delivery. They're injecting mothers who are having their babies with heroin because of its pharmacokinetic profile. It might get less to the baby. So heroin is actually still, to this day, utilized in labor and delivery just across the pond. So this scheduling is pretty soft when you really look at like what the rules are, so to speak, and what the criteria are. So you probably heard it's pretty exciting that there might be a change coming. But we have to remember where we got here. Remember 1996? That was under compassionate use. The Prop 215, which I think I have on the next slide. Yeah, Prop 215 is compassionate use. Californians said, yes, we want to legalize cannabis to use it for medicinal purposes, but don't make a commercial market out of it, right? You can grow your own, you can share it with your friends, you can create collectives, but you can't necessarily do that. So that was Prop 215 in 1996. Jumping back, though, remember, that's compassionate use. And where I'm going with this is it time for national legalization? And I'll bring this kind of point up over and over throughout the talk, because right now we have a very scattered system. Actually, we have a pretty clear system, right? That's the picture down here at the bottom. What is the legal status of medical or of marijuana? Right there is what you actually have on the federal books, right? Currently, cannabis is pseudo-legalized because, and this gets a little confusing, but because the executive branch wrote into essentially its budget, and in its budget said that we will spend none of our money on enforcing laws that marijuana laws that disagree with state marijuana laws. So it's just a line in the budget, the congressional budget, and hypothetically could be removed at any time. I know that sounds crazy, and I don't think it will happen. But as it stands today, the only thing standing between the DEA busting down the doors of a dispensary in your home state is one line in the criminal justice code that says we won't spend our funds on enforcing these laws, because the true legalization status of cannabis is at the bottom. And what we have is this patchwork or framework of adult use, medical use, and CBD only throughout the whole country. So we have different situations in every state. But this is changing. The upcoming DEA rescheduling hearing is coming up in December, and they're going to be discussing, well, can they rightfully and, in good faith change medical marijuana or marijuana in general to a Schedule 3 substance? So taking it out of Schedule 1, where it sits with heroin today, and bringing it to Schedule 3, where it will be with ketamine, anabolic steroids, and a prescription isolate of Delta-9 THC already. That's how biased this war on drugs has been, this war on plants, is the active, the most powerful molecule in the average marijuana is already a Schedule 3 substance with accepted medical use. It's been there since 1984, before we even understood how it worked. And yet here we are having the conversation around where should the marijuana plant fall into this drug category. It's kind of crazy, but that's where we are. Now, I don't want to poo-poo too much about C3. I think there is something really good to say, which is this. Health and Human Services and FDA both come out and said that cannabis, marijuana, should be rescheduled to Schedule 3, which inherently acknowledges that there is acceptable medical use. And that would be, ladies and gentlemen, the first time in history that our federal government has acknowledged that, which is insane for those of us who know about the medical properties, or for our ancestors who well knew about the medical properties. But here we are. So that's pretty exciting. But I want to point out, everyone, that DEA does not have to do anything. They are expected to, but they get to make their own decisions. There isn't anyone except for the director of the DEA who can make these decisions. They're getting a lot of pressure from the executive branch, from the presidential branch, but there's a lot of competing interests. And so it's not going to be that simple. Then the question becomes okay, cannabis has gone Schedule 3, what impact does that have on all of us? We have to think through these things. What does that mean for pharmacies? Are pharmacies going to be the dispensaries now? What's happening to existing dispensaries? Will existing dispensaries need to register with the DEA? There are a lot of questions and things that need to be planned out and that we need to be thinking about is this the way that we want to see this regulated? Or if not, how do we want to do it? So I hope that everyone is thoroughly convinced that we've got a bit of a mess and there's a lot of work to still be done. And as we go through some of the issues and considerations for moderation, let's say, or balance, I think that we need to be thinking about, this isn't a balanced approach. In fact, it's extremely imbalanced. The weight of what's happening on the West Coast is influencing what's happening in New York. It's the price of cannabis on the West Coast, especially in this pseudo-legal mixed bag situation, is drastically impacting the price of goods in other places. For example, Oklahoma is one of the most prolific producers of marijuana in the whole country. Yet, if their citizens were to try to consume all of that marijuana, it would be pounds and pounds per citizen per year. And so where is all that cannabis going? And you can imagine that it's going internationally. It's being transitioned and converted into molecules to be sent all over the world. So this hodgepodge thing, yeah, it feels like it's working, but this is the compassionate use approach, right? This was us saying that, hey, we need to provide access to our citizens, but maybe now it's time that we demand to our regulators that we make sure we do something different. Once again, California passed Prop 215 in 1996. These are the individuals who are in favor, okay? My next slide, it gets a little confusing when I was putting it together. This is not voting, okay? This is the result of voting that occurred in 2016. Prop 64 was Adult Use Marijuana Act, similar to what was done in Colorado, kind of treat it like alcohol. And that was passed in 2016 by the voters and went live in 2018. But look at this map. Does this look like a good map? 46% of cities and counties in California, the most progressive place. People think of this as the Mecca of marijuana. Only 46% of counties and cities allow the sale of cannabis. So you think we've won? I'm here to remind you, no, we have not won. We have made progress on the grounds of compassionate use. We need to keep going and we need to decide what that looks like instead of just accepting what is coming our way, okay? My personal issue with this market, there's no difference whether you're a medical patient. Look, the Department of Cannabis Control, of Cannabis Control, went ahead and they don't even tell you which one's medical and which one's not, right? Because when they adopted adult use, it sort of just got gobbled up in the process and frankly is not a focus. So that's my biggest annoyance with this current situation. Now, one thing that I pulled this graph from New Frontier data. It's a little old, 2019, but it was predictions. It lines up with the current market predictions. I double checked to make sure that these were sort of still co-trending together. This is still estimated to be the approximate value of the adult use and medical marijuana industry in 2024, between 27 and 32 billion dollars. Great, except the black market continues to outpay or continues to outperform nearly double or potentially even more, right? Because these are hard numbers to gather, particularly hard numbers to gather. So think about that. There's still a high demand for cannabis, despite in 2014, I mean, a lot of states were going medical and adult use. This is not changing. Now, you can see a decrease in demand, but not a relative one for the black market cannabis. Eventually, with adult use and everything, we should be able to suppress the demand for black market cannabis. However, what's not reflected in these numbers, in all of these beautiful, look at how much the adult use market is growing, is that all of the stakeholders, all of the good guys who wanted to enter the market legit and do it right, they got creamed, crushed, sucked up into the vacuum that is commercialization. And a lot of them went back to the black market, frankly, and started selling in the legacy market again. And those that didn't have been replaced with, unfortunately, the bad guys. This is organized crime who's coming in to try to, instead of import marijuana, historically, what organized crime was doing is they're now just growing it here. And it is a problem. It's not our biggest problem, but it is a problem. Some of the biggest problems, though, that are leading to this to continue happening, we've got enormous licensing fees. We've got insane barriers to entry, like in California, where you have to present, if you want a grow operation, an absurd amount of liquid assets in order to start that grow. Where other states, such as Oregon, didn't do that. Tax burden, this is really big for our industry. We need to think about what taxes should look like. Right now, we've got sales tax and we've got double dipping on that sales tax. You got the processors being taxed and the sellers being taxed. In certain states, you've got extra sin tax, putting alcohol, tobacco, and cannabis together. And then perhaps the biggest problem for most industries, and the reason so many business owners are interested in Schedule 3, is a tax known as 280E. It's essentially a tax set up by the US federal government to prevent racketeering and organized crime from washing their money. And in the process, because marijuana is a Schedule 1 drug, the cannabis industry got swooped under that 280E tax. Now, I don't know what that number is. There are license holders, operators who know this tax extraordinarily well. That's not what I do. But here's what I know. I know it's crushing people, right? And so people are grasping at strings and they're really interested in Schedule 3. But I think that, regulators know this and they know that we're willing to accept, that relief wherever we can get it. But the question is should cannabis, be falling under these same taxes and, medical cannabis? So the challenge is the legal market, which are listed above, rules, regs, burdens, compression, politics, has all led to churn and a loss of legacy producers, and filling those voids are organized crime. So we have not yet fixed the problems. And part of this is, again, access. It's about limiting licenses and limiting entry to market, leaving voids. And where there is a void of demand, I assure you that the legacy market will fill that void, as it always has. Now, change is happening. Once again, federally, this is what the country still looks like. But state by state, just 25 years ago, 27 years ago, we had this is the market, and we have come a long way since then. This is a little graphic I made. It's not perfect and it's a little dated, but know that this is a constant evolution and it's still happening. On this graph down here in 2021, Ohio was medical only. Now it's adult use. Georgia is now selling their CBD, low THC medical cannabis products right out of pharmacies. The DEA said no. One pharmacy said yes. This is clashing happening right now. It's so cool to be in the middle of this history with you all. In Nebraska, they're voting next week, right? They could pass medical cannabis for the first time. So much happening. It's staggering, though, how much can change and how quickly from state to state. I literally don't know what's happening in your state. I'll ask you where you're from. I'll ask you what's cannabis like there because I'm not sure. What is there a pharmacy requirement? Is it adult use only? Is it super limited like Texas where there's only three places to get your medical marijuana in the whole state? I don't know. It's hard to keep up. And then you cross the border and this medical marijuana you have in your right hand becomes illegal marijuana across the next border. So we've got a problem of continuity, and there is a tremendous need. It's pretty clear from this map that there's a need for comprehensive federal reform, but maybe not always as much demand for comprehensive federal reform, because that means shaking the pot and upsetting the people who have, let's say, laid their hand out in a way that's beneficial in the current market rather than maybe the market that we all deserve. Oh no. Um, this graphic that didn't show up right here, I wish it did, is a picture of how fast THC levels are going up. Okay. And what you can see is if you go back to the early 1990s, you'll see the average seized cannabis or marijuana product by the DEA was somewhere around 4%. You can't see it, sorry. Was somewhere around 4%. And then in 2020, 2022, the average seized by the DEA was testing around 16%. So that's a fourfold increase just in a matter of 25 years. Look, a big fan of THC. I certainly don't think we need to be putting caps on it. But I do think, okay, so a market hyper focused on THC, who's the winner, right? Because this is what we have. We have an industry that is focused on THC, was forced to breed, focusing just on THC, sort of in the dark during the legacy market days. And as such, we've had THC levels rise over time. It's not a coincidence. These market influences and demand from customers drove THC up. Another factor that was involved here, unintended consequence, is we started mandating that everyone test their marijuana for THC. And at minimum, that be the factor that they place on the product. Now, I don't know about you guys, but if you think about incentives, or the way people shop, right? What are we looking at? We're looking at maybe cost per gram or cost per milligram, right? And that's the only data point we really gave consumers to drive their decisions, especially when we took their sensory perception away from them, making this a CPG, putting it in the back room, locking it up as if this herb was some sort of, crazy addictive booger sugar that people were just going to run out of the store with instead of smell it like a spice or an herb. Anyway, I digress. When we decided that THC was so important that it needs to be listed on every single package, we gave people a value indicator, and it has falsified their belief in the value of this indicator now too. So everybody starts shopping for THC, which means that the dispensaries are only moving high THC product. Therefore, they want high THC. Therefore, the growers are going to grow it. You can see how this incentive structure led to, we'll call it an arms race of THC, which once again, if you could see this lovely graph, it would be slowly trending up over the 90s from 4% to 15%. And you would see the average CBD and C samples would be running along the bottom axis, basically unchanged or even decreasing until recent years. Now, what can come of that, right? So that's undeniable, right? A lot of this cannabis industry says, oh, that's an association. We can't, okay, that's fine. But we do know that is increasing, okay? And what could come up if THC is increasing? So I wanted to address some very specific things that are commonly cited, talk about what we currently know, what we should be thinking about and contextualizing. And if you chatted, Jim, I'm not looking at the chat. I see there's a few in there though. So please interrupt me or, let me know. I don't mind the interruption. I want to address some common concerns. So here's 5 big concerns that come up in my mind. To be honest, now that I'm looking at this and I did this presentation today, I don't think I addressed driving. I'm sorry, but I just don't think it comes up. We can talk about it briefly. But before I can talk to you guys about how THC may be contributing to any of these conditions, I need you to understand what the endocannabinoid system is. This is my favorite topic, but the endocannabinoid system is a master regulatory system, a system that is present not just in your brain or not just in your lungs, but it's actually present in the vast majority of cells in your body. Okay, so not just the organs or the tissues or the systems, all the way down to the cellular level. So a cellular communication system shared by all vertebrate, things with a spine, every animal with a spine, the birds, the lizards, the dogs, the fish, the sharks, all of them have an endocannabinoid system, and it regulates countless functions. But one of the biggest things is our neurotransmission, our perceptions of the world, our cognition. And so introducing THC can alter our pathways in our body and brain. It can affect the way we perceive pain, the way we perceive the world, the way our GI system works. It can alter the way that our brain develops. So this is an incredibly important system that THC sort of functions as a hijacker, or like the cheat code, the master key, we could even say. So THC is acting on this incredibly important, widespread, ubiquitous system inside of all of us. So is it really that much of a stretch to think that with increasing amounts of THC, definitively known, and increasing amounts of use over time, I'll have a slide in a minute, is it that unreasonable to think we could have more of these problems growing? And are those problems really, let's say, stop flags or just warning flags? So these are the things that I want you to be considering. So psychosis, all right? This is a concern. Patients who lose touch with reality, right? They can be caused by a number of things. One of those things is mental illness. We call that schizophrenia, right? It can be induced by what is the word? They put people in prisons where they can't interact with everyone. Solitude. What's the word I'm thinking of here, Jim?
Solitary confinement.
Solitary confinement, right? So this is something that isn't even listed here. It's not a drug, but if you put someone alone in a room for long enough, they start to lose touch with reality. It can include hallucinations, delusions, disorganized thoughts, and behaviors. Okay, so people aren't making much sense. Now, psychosis can happen from cannabis. It's one of the substances. I would point out it can happen from alcohol, it can happen from methamphetamines, it can happen from regular amphetamines. But yes, psychosis can happen from marijuana. Now, we are dealing with two different kinds of psychosis. We've got acute THC-induced psychosis, and then we've got the concern that's more commonly cited, which was schizophrenia in chronic THC exposure. So, what do we know? You can definitely have acute THC exposure. Not to call out my best friend from high school, I won't share, college, I won't share his name, but we once made brownies that were far too potent, and he thought he was growing horns. Now, eventually we talked him off the cliff, but he was convinced he was growing horns. Now, this sounds wild, but it can happen. In pediatric patients that we've taken care of in the hospital, we can see little children who've accidentally taken far too many edibles. Their life is not at risk, but they are playing with something in the air that is not there. They are actually hallucinating because they had a large dose. THC can induce these sorts of hallucinations or psychotic symptoms in large doses for short periods of time, almost always transient. Now, what's less clear is, can THC set off a condition that is schizophrenia, that is a condition of sort of relapse-remitting psychotic symptoms? And the answer to that question is far more challenging to tease out. But it's annoying me that these were working earlier, but not now. So side effects of psychosis, right? If cannabis use is on the rise, this is the same picture, by the way, of my increasing potency. So clearly there's an issue with that. Cannabis use is on the rise, and you can see that. So daily or near daily use is what we're looking at with the yellow dotted line. You can see there was a little more near daily use in the 70s, and it really went down during the DARE era and during Nancy Reagan's very successful campaign. And then California legalized marijuana, and all of a sudden everything it started to go up. And now you'll see a lot of headlines right now. There are more people using marijuana every day than there are drinking alcohol every day. Now, Is it a perfect substitute? No, probably not. Comes with its own risks, one of those being psychosis. But I would point out that marijuana is not directly associated with domestic violence. It is not strongly associated with car accidents compared to alcohol. It is not strongly associated with cancer, which alcohol is. And the associations between depression and marijuana use are far less strong than depression and alcohol misuse. So there's a lot of things to unpack here. But with the rise in potency, which is this invisible picture here, you've got THC going up over time. CBD is not changing. Use of all these products is going up dramatically since 1990. I mean, we're talking about 8 or 10-fold increase. So if marijuana causes psychosis and potency of marijuana is going up, then I'm definitively going to see a rapid increase in schizophrenia, right? Yeah. So that's not what we see. And in fact, the data is rather hard to come by here, but a couple things I wanted to point you to. Here's a study out of 2018 that looked back over studies published between the 1990s and 2010, 2012. You can see that numbers estimated in 97, right here in the UK, will line up with 2003, 1998, and numerous other time points between I can't remember exactly the time frame on this study, but it's something like 1995 to 2012. All of these studies were estimating about the same prevalence of psychotic disorders, including schizophrenia. Okay, so even over the time frame, which we just elaborated in the last slide, between 1995 and 2010, we saw a 3 to 4-fold increase in marijuana smoking of daily or near daily users. Yet in this study and in this study and in the future predictions that pharma is making about schizophrenia, we don't have dramatic rises. So even the pharmaceutical industry doesn't believe that marijuana is causing schizophrenia. Otherwise, their predictions would be that this is going up. Another example is this is global prevalence of schizophrenia globally. It's trending up, right? Well, what's happening to other drug use? What's happening to synthetic stimulants right now and into the future? It's going up. So we've got a lot of other drugs causing this, and we could easily explain it. So, ladies and gentlemen, I would argue that cannabis is not causing chronic schizophrenia and psychotic disorders, but it definitely can. And I have seen personally patients experiencing acute psychosis. And I've experienced patients who are experiencing some pretty abnormal experiences on cannabis. Let's say prolonged periods of not feeling like themselves, dissociation, or can't remember the word right now, but these can be predictors that potentially they're at risk of schizophrenia. It is believed that THC and THC exposure can hasten the diagnosis, can hasten the experience of developing schizophrenia, but at this time it is not causative. And all of the three images that I'm showing you on the screen are pretty in support of that because there's just so many more people smoking marijuana today and starting in the 90s than there was before. And the numbers just do not reflect that gross increase in use. As I mentioned, addiction is a concern, and it should be a concern, but it should also be a concern when we're talking about other substances too. Now, our understanding of cannabis addiction, cannabis abuse, this is an ever-evolving thing. You know, if you go back to reefer madness in the I think it's the 40s, it was pretty extreme. Women cry for it, men die for it, reefer madness. I think Dave Chappelle would make a strong argument around what men are willing to do in order to get their weed versus other drugs. I'll leave you to find that on Google. But here's what I want to show you, perceived risk. You can see again in the early 70s, a lot of high schoolers didn't really think weed was bad. We had a pretty successful anti-drug campaign through the early 90s, really making almost 80%, 8 out of 10 or 4 out of 5 kids believing that there's a pretty high risk But then that number really started to trend back down into 2013. If you continued this graph, I'm willing to bet it would even go lower. I don't have that information in front of me. But really, there's been a pendulum swing. Marijuana is bad, no, or marijuana is good. Marijuana is bad. We're swinging back to the marijuana is good, and the truth is somewhere in the middle, y'all. Yes, we can develop a problem with this substance, like we can with almost everything. Sugar can be addicting. My weird addiction is a television show. People are eating couch cushions. So like, there's a lot of things in this world that the human brain can convince us to do. And I'm not surprised that this mildly dopaminergic drug does carry some risk of abuse. Now, here's how. I don't have this isn't actually my favorite slide, but it was the best I could come up with. But it's just simply understanding the way THC interacts with our CB1 receptors in our brain, which, by the way, are the most abundant G protein coupled receptors in the brain. So it's no surprise that this has broad, varying effects in different individuals with different diseases because the system is so widespread. But generally speaking, what we have is THC alters the glutamate GABA balance. That slight increase in balance leads to a slight release of dopamine, and the dopamine rewards us in our reward pathway. So unlike cocaine, which has a very direct, or stimulants, which has a very direct effect on dopamine, the effect of marijuana on the dopamine system is much more nuanced, which explains the addiction rate being significantly lower. Now, historically, this number was about 10 or maybe 1 in 8, so 12.5%. Doing the research for this very project, NIDA has altered that claim and now are saying that 22 to 30% of people who use cannabis have developed cannabis use disorder. Now, I thought that was interesting because it was only a few years ago I was getting my master's degree, and that was very different language, but that's where we're at. Now, all these things that are good, right? Reward in an animal, decreased anxiety in a human, increased socialization in a human, these good things, they, under chronic stimulation from THC, this is from mostly animal studies that we found, can actually lead to more problems, right? So it helped you with your mood before, but now you have a depressed mood. It helped you with your mood before, but now you tend to have more anxiety, which could explain the anxiety associated with marijuana. It's a change in the balance of the system on chronic use or with withdrawal, and we can have some of these negative symptoms. Cannabis withdrawal is absolutely a thing. Historically, they said no such thing as withdrawal from weed. We know that's not true. It is just mild and looks more like tobacco withdrawal than it does something like alcohol or benzo or opioid withdrawal, which is deadly or just feels like death. In the case of opioids. So there are definitely problems associated with chronically stimulating our THC receptors. There is definitely a percentage of individuals who are developing a use disorder, spending too much of their time, too much of their energy, too much of their money on marijuana. But let's keep that all in context. Pornography is addicting. Food can be addicting. Even positive things or things that you think of as positive, such as exercising, can be addicting to a negative degree. So everything in context is sort of the conversation that I'm here to talk to you about today. And I hope that you're getting that, if nothing else. You probably heard Jim say that I'm doing some research in cannabinoid hyperemesis syndrome because I am extremely interested in this condition. I see it regularly in teens in the hospital I work in Southern California. Not exaggerating. It's almost a weekly occurrence. And I try to understand these children. I try to help them. Again, I said children. They're usually teens at my institution. And so there's a weird syndrome that's popping up among heavy weed smokers that is defined by intense, persistent nausea, weight loss, and vomiting for extended periods of time, 24, 48, 72, a week sometimes. Uncontrollable vomiting, which can lead to electrolyte derangement, and has now been associated with numerous deaths, believe it or not. So cannabis has never killed anyone. If we haven't formally changed that word, I think that we probably are. But let's also note that, no substance is perfect in the fact that, cannabis had a perfect record or no longer has a perfect record doesn't mean that we should vilify it. I would say it just means that we're back here in reality and the pendulum is swinging more properly to the middle. Now, a couple things I want to point out. 2 studies, Both of them looked at things happening before and after legalization and incidence. So you can see that we've got data between 2014 and 2019 in Canada before legalization. And these are cannabinoid hyperemesis ED visits for every 1,000 ED visits. So for every 1,000 times somebody came to the ED in 2014, there was zero point 0.1 of a patient. So that means one patient in every 10,000 had CHS. After legalization, 6 years later, it was much closer to 1 out of every 2,000. So rates had increased fivefold, and now rates have increased tenfold after in 2021. Okay, so this is one example of looking at Ontario data of CHS visits associated with ED admissions. Same thing, except done in Oklahoma. This study was done looking at admissions for pre-legalization, having to do with hyperemesis in the hospital, just one single center or maybe two centers in Oklahoma. And they looked at the trend line over time. And then over that same timeline in blue, which is the dates above, you can see that there was an overall increase in the prescribing rate. So it's certainly this is the increase here of legalization. So there's a rise, and I don't know what's causing it, and we need to get on top of it. I'm here to tell you that this is a real syndrome. I'm also here to tell you that it is uncommon. We can treat it by reducing people's use. But the problem becomes is that these individuals are often those same 10 or 20% of individuals who developed use disorder and have a lot of trouble quitting. For most people, this is no big deal, but there are some people that become highly dependent and use cannabis and marijuana to cope and deal with their trauma or their abuse. And so there can be a lot of challenges associated with this condition, accepting the diagnosis, and even more challenging, enacting and following abstinence in this case can be a real challenge. Let's be honest. Abstinence has always been a real challenge. But here's the mechanisms of this condition we really don't know. But we know universally or near universally, we're talking about patients who are using many times a day, almost exclusively high THC products. We believe that probably leads to an endocannabinoid system dysregulation, facilitating somewhere in all of these conditions, also associated with genetics and underlying mood disorders and potentially motility disorders leading to CHS. So we know this part, excessive high THC, and we know what the syndrome of CHS looks like. But how it's happening is still pretty much in question. Even this endocannabinoid system dysregulation is pretty speculative. But we do know that we have a lot of factors involved. We can't figure it out. If you talk to people on the internet, they will tell you that it is pesticides. And I can't deny that, or I cannot deny it as a possibility. In fact, no one can, because no one's done any research as to what truly causes CHS. But there are reasons and places where that theory breaks down, specifically having to do with the hot bath complex, some cycle stuff that goes on, and potentially even this hypothermia, which has been pretty commonly correlated. So we don't know. But CHS is happening. It's happening more and more, unfortunately, and we need to get on top of it and figure out how to best mitigate this risk, as it's a problem that if we don't get ahead of, could get ahead of us, and it could lead to a PR nightmare for those of us in the industry, especially if you're a healthcare professional. Knowing about this, educating on this, identifying it early, and having real conversations with patients is the best thing you can do. And I had to do it because I'm a millennial. I had to do the fun. But what about the children? Right? Everybody's worried about the kids. I'm sorry. Before I move on to what about the children, I'll stay on this screen for a second. I want to address driving. There is emerging evidence that consuming THC before driving affects some individuals negatively. Not all, but some. Who's affected negatively? We have no idea. So it makes sense. It is common knowledge to not consume and drive. Now, there are major problems in the way that testing is being done for driving. If you're testing my urine for something that lasts for 30 days, but is only impairing for 4 hours, this is nonsense, right? So when it comes to the driving question, what we really need is thoughtful regulations that are truly looking for impairment rather than the presence of a metabolite of a drug. Some of the world's leading research in this space is coming out of UC San Diego. And at UC San Diego, they said, I'm paraphrasing a lot here, but simply only about a third of people who are consuming cannabis and driving are impaired. But of those who are impaired, there's not a lot of predictions, and people who thought they wouldn't be impaired sometimes are impaired. And so there's not a good definitive thing. The other thing they found was, generally speaking, 3.5 to 4 hours is really the impairment window and no more. So someone who consumed, let's say, cannabis the night before is fully, equivalent to their baseline just 4 hours later. So those are a couple things about driving. Yes, there is some impairment in some individuals. We can't really be sure who that is, so we must develop new and better tools to better identify it. Okay, that was my driving. Sorry, I forgot that section. Okay, what about the children? What are we going to do about the children? We're going to address the concerns head on. The biggest concern, the one that's cited by most prohibitionists, is this gateway theory. What's going to happen to them when they start smoking reefer? Right? Well, they're just gonna be set off, and the next thing you know, they're shooting heroin, and they're on the streets, begging you for a xylazine. Now, that's just not true. We were led to believe that at one time, but it's just not the way this works. And in fact, I want to use NIDA's own language, the National Institute on Drug Abuse, who has been very negative towards cannabis historically, had to back away from some of that negativity in recent years because the data is more mixed. Here's what they said. Cannabis products are among the first substances, along with alcohol and tobacco, that a person will likely encounter. And people who use those substances commonly before these, or will use these substances before trying others. But most people still who use cannabis or do use it do not go on to use more substances. So NIDA themselves has debunked the gateway theory. Now, there is a current gateway theory, and that's alcohol, tobacco, or marijuana use at a young age with regularity is the gateway, right? You start using any of these substances a lot as a young person, then you're more likely to have a problem. But this idea that cannabis is some sort of the drug to inspire you to use other drugs is nonsense. That said, there's absolutely a correlation, right? The correlation they made this on people who use cannabis and people who are open-minded enough to use other drugs. I don't think that that's a shocker, but you'll find the same thing with alcohol and the same thing with nicotine. So what do we see when we look at teen use? I know it's going to come as a surprise, but here's The Guardian just last month. Look at that. Cannabis use falls among U.S. teenagers here in 2024. So we've legalized all the weed. It's everywhere. We commercialized it. It's cheap. It's accessible. But now the kids want it less. And this is sort of like, go ahead, Jim.
Did want to shout out a question in the chat.
Perfect.
Should a young developing brain use cannabis for anything other than medical use or conditions?
Certainly, I'm not a proponent of a child using any substances that alters their cognition, but I want to be clear. The concerns about a child's brain, which are founded in science, the ECS is critical for the development of the brain. We know that chronic exposure at a young age can have a deleterious impact, but I want to point out that data is only in adult use or not adult use, recreational use. And it's never been shown in a medical trial. So there's currently no reason to refrain from using THC in a medical context, but there is a good reason to discourage our youth from chronically, consuming a psychotropic substance. And I don't think that'll surprise anyone that the developing brain shouldn't be dependent on a substance to help them cope. And then what we see later in life is we see some memory challenges, we see motivational challenges, attention challenges. I guess that's memory. But overall, the impact, even with chronic use at a young age, is not straightforward. forward. There are many people who've consumed from a very young age who are highly successful, and it's not a linear, it's a correlation. But the good news is you have even less of that to worry about because in just the last 10 years, we saw over a 10% decrease in the amount of kids that ever tried marijuana. We saw nearly a 10% decrease in current marijuana consumers and almost a doubling or a halving of the under 13s who are trying marijuana. Legalizing marijuana does not make kids consume more marijuana. The data is clear. This isn't some these are NIDA supported studies, right? This comes from the same sort of propaganda circle that we would have criticized as the cannabis industry. Same thing over here. Another look at the year by year use in cannabis, and this one divides by age. And I want to point out there's only one line on this whole chart that isn't rising. And that's the kids. The 12 to 17s are not using cannabis more, despite the fact that between 2013 and 2023, at least 20 states turned online, right? Like 20 states turned on an adult use program. We saw no change in teen use. Now, we did see a pretty significant change in 18 to 25s. And remember, those were the kids who were kids not trying it when they're younger. But it turns out that making it legal actually increases appropriate age use. The thing that we see the most use of, though, is the 26 to 34s. And we're seeing a rapid increase in, maybe the most dramatic by a percentage, in senior citizens. So legalizing cannabis doesn't increase kid use, but it does increase adult use. And should that be a concern? Should that be a concern? Let me just finish that thought. We should be thinking about what the side effects and implications are of anything that we're doing chronically. But if we compare it to the daily use of alcohol, it's unquestionably better. So overall, I would say, yes, it is an improvement. We probably have some work to do around mindfulness. We probably have some work to do around mental health. We have a lot of work to do in other spaces, but this is not the sky is falling, marijuana is legal, we got to worry, everything's going to go to shit. It's quite the opposite. Everything continues to chug along, except for more adults are using more cannabis. And the other correlations are really not very strong. Not more schizophrenia, very few increase in driving. Yes, we have accidental ingestions in older people, but we just need to be thoughtful and mitigate them. So then I want to talk briefly about balance in regulations, jumping over from pediatrics and all of the health stuff over into like what we're talking about. And this really comes down to hemp, right? There's a lot of riffraff and talk in the industry right now. It's like the hemp cannabis civil war, you've heard it called. I've cited it saying that. There's a lot of pushback. Marijuana wants to keep hemp out. Hemp wants to sort of loophole or break the rules and says basically all cannabis was legalized in 2018. It's confusing, but in simple, the government defines these drugs or these plants as such. Marijuana is a plant that contains more than 0.3% THC by dry weight. I want to point out, they said very specifically in their law, THC, not THC acid or THC equivalent, THC. Now, most marijuana is very rich in THC. It doesn't have to be. Can be used for both, right? Medical and adult use. Usually we have hemp for medical purposes. We know that it's any plant containing less than 0.3. But then that leaves these questions about THCA, which is the precursor to THC, THCO, which is a semi-synthetic equivalent to heroin for marijuana, and Delta 8, which might even be technically naturally occurring. What does this mean? How do we strike balance in this market? Remember, you have to have a little bit of history to understand this concept. So in 2014, under President Obama, big research grows were legalized, and there was a huge rush for hemp. During that rush, and there was a lot of hope, especially in conservative red states, Kentucky, Tennessee, and other places like that in the Midwest that's great for growing hemp. They pushed hard, and Republicans and Donald Trump passed the 2018 Farm Bill that allowed hemp products to be sold, not sold, sorry. It led to what I would call a CBD green rush. And of course, that led to a crash in the CBD price. And then people had to figure out what to do with it. So they started making isomers. The rest is sort of history there. And the Farm Bill, which is supposed to be renewed every I want to say every 4 years has been delayed till 2024. Now it's going to be delayed till 2025 as we try to figure out what the heck we're going to do. But it will change what is happening with Delta 8. Now, all in all, what I just said is the current legal status of cannabis in America is essentially it's all legal except that THC, which is only found in processed marijuana or cannabis products or in small amounts in cannabis flower. Now, keep in mind, even though the rules say no marijuana, the hemp farmers have gotten to a point where they're not calling their marijuana marijuana. They're calling it THCA flower. They're selling it in, 3.5 gram increments in glass jars, just like you would find marijuana. It's very rich in THCA that when smoked turns into THC, but it is, hemp. And so that's the current state of affairs where we're making synthetics. We're selling marijuana under the guise of hemp, but currently marijuana remains a Schedule 1 and one of the most tightly restricted plants on the planet, but all this other stuff goes. So it's kind of a mess. And you think, well, fine, leave it as it is, right? It's working, right? But this isn't as straightforward, okay? Chemists are raising the alarm about the stuff that's popping up in these products because these products are not extracted from plants, which do things consistently. They are extracted from a plant and converted into something that's psychotropic. And in the process, there can be a lot created. The DEA and FDA know this. FDA has announced, hey, you need to know about these serious health risks. The DEA technically says that Delta 8 THC is illegal. It's just that the DEA rule conflicts with the hemp bill, and so now they're butting heads legally, and no judge has overturned that. In London, a woman who was eating a synthetic cannabinoid sweet dies, right? We're supposed to say that cannabis doesn't kill anyone, but can hemp-derived psychotropic cannabinoids kill people? I think that the answer is probably maybe. Delta 8 has impurities. There's a lot of really smart people writing about this. You can find papers left and right. There's dozens of byproducts being produced in this process. And there was a mom who, in a case of neglect, accidentally or allowed her child to ingest Delta 8 gummies, and that child died. I think the little boy was 5. And the concern is, well, what happened to that little boy? Is it the Delta 8? Is it the cannabis? And the answer is that doesn't really matter, but it proves where I'm getting at. This Delta 8 has no regulations. There's no strong rules around what sort of packaging it needs to be sold in. There's no special place where it needs to go to get tested. There's a lot of ambiguity in this space that could be tightened up. And there are a lot of smart people sounding the alarm with, hey, why did we make marijuana hella illegal and keep it that way, but now we've legalized making drugs that are sort of like marijuana, and that's fine. That's the part that's kind of dumb. So what could we do differently in regards to the regulations? I think language matters. Language matters. What words we use, THC versus THCA equivalent, like that one word equivalent can change everything. That's just one example, but words matter. I would even propose there's better language, but we're not going to get into that. So make sure we have experts and stakeholders involved in rulemaking. The right people weren't in the right chairs, right? That's you. If you're listening to this, you're clearly interested in this topic. Talk to your regulators. Tell them you know things about this. Tell them you know people who know things about this, and be supportive for them. Get involved. Treat plants, i.e. marijuana or cannabis sativa, differently than you treat drugs. Now, this is a little bit of my opinion, but it's also common sense, right? We don't treat corn even like the way we treat alcohol, which is made from plants. And so even though I think alcohol is still treated more openly and less stringently than cannabis, but you don't treat the plant as if it's the product made from that plant. Those need to be regulated differently. So framework should orient towards each industry. If Delta 8 is safe and you can prove it and you want to sell it to people, I'm okay with it. It probably is safe, but prove to me that the product that you're giving to consumers is safe and that it meets a standard regulatory framework, which needs to be built. Delta 8 by conversion should be treated differently than Delta 8 by extraction. If I extract something from a plant versus if I make something in a laboratory, those should be treated differently and should be thought of differently in the law. And I believe that this is something that we need in our future regulations. And then, for me, national uniformity. right? If I in Pennsylvania say that Delta 8's synthetic and Delta 9's natural, but then New York decides that Delta 8's natural and it's not, are you going to break a law when you cross over one product to the next state? What kind of craziness would that be? That wouldn't be pushing us forward. That would be dragging us down and wasting our time. Again, let's talk a little bit of balance in research. I just talked about balance in regulations. So headline grabs are easy. They're all over here, right? Just all from this year. The head and neck cancer associations and associations with heart attack and stroke and education and psychotic disorders and academic performance and this big article from the New York Times is so does marijuana's use grows, so do the harms. First of all, true, right? If marijuana use is increasing and there's even a 0.0001% chance of a harm, that increase there is going to be a relative increase. And I think that that's pretty well known as we learn more about the cannabis plant, like genetics, those individuals that might get CHS, we're going to learn more. So yes, as marijuana use grows, so do the harms, so does the knowledge, so does the awareness, and so do the treatments. So we can grow with these problems. But one thing I really want to focus on is just like the media, the research is also biased, okay? Headlines are easy to find, easy to get, but the science in all of these articles is way more nuanced than what you read. And the science is often funded by NIDA, and NIDA is specifically interested in proving that cannabis is scary. They spent $1 billion on NIDA over this time period. I can't remember, 2000 to 2018. $1 billion to NIDA to prove that cannabis is dangerous. Meanwhile, the Cancer Institute got less than 100 million to research how cannabis could help cancer and should be a top priority. This is a horrible disease, right? Even if we end up developing a cannabis addiction, we know that the withdrawal is tolerable. We know that we can get people through it. But cancer deserves some time and focus. But it has something to do with patentability. It has to do with politics. But in general, I hope it's pretty clear from this graph that there's a bias problem, and we need to do better communicating that. And also, leveling the research field. So there's a lot more positive publications than there is negative publications. The news reports on what come out. We need to tell Congress to allocate spending to find the benefits. Excuse me, because you couldn't get through this talk without at least one AI generated image. This was a pretty picture I put together for an industry for everyone. So on the next slide, I explain a little bit more on how we can bifurcate this, but I believe in a trifurcated future of cannabis. I think it can be all of the things. I think we can keep our adult use dispensaries and that we can continue to treat alcohol or to treat marijuana like alcohol access. But I don't believe that that's a service or a route for everyone. Now, I'm biased, but I think that cannabis is medicine, and medicine should be coming through the traditional channels of a doctor, a pharmacist, support from nurse, etc. And as such, I believe that there should be an option to get prescription cannabis that can go through your insurance, that can afford you the same rights and protections. If we make cannabis federally legal, let's say a Schedule 3 or a Schedule 6, and declare it as medicine, your access to that medicine will be protected under the Americans with Disabilities Act. The same way that you're entitled to an elevator or a ramp at a restaurant is going to be the way you're entitled to take your cannabis medicine with you while you fly and no longer be a criminal in another state. So I think that there's a real option for the medicalization of botanical or, botanical extracts, all isolates, whatever you want to do. And this isn't some novel idea. Australia is doing things like this. There are other parts of the world that are utilizing pharmacies. And then lastly, I think that pharmaceutical companies they're wise to this system in which they can leverage to make medicine. They're wise to the idea that there could be money to made, that there is a therapeutic effect in this. But remember, they're interested in making money. It's not the march of dimes. They're interested in drugs that are patentable, which is not the cannabis plant. And so don't expect them to enter the traditional pharmacy route, which is one of the hindrances with Schedule 3. Right? These companies who have the money to enter the market are not very interested in this middle route because they get no protections for their products that they make. So we definitely have a challenge, but there's room for everyone and all the cannabinoids, the synthetic ones, the natural ones, and the ones that are still in flower form. The biggest unknown to all of this is legalization. What does it do? Are we going to Schedule 3? Are we going to Schedule 2? That's a possibility we didn't even discuss, right? Could the DEA come back and say, no, sorry, we think it's too dangerous. We'll do Schedule 2. It is a possibility, although not a probability. Um, depending on what happens with legalization, it goes to a FDA. FDA is going to treat it like tobacco. If you look at tobacco, we've got kind of a mess of what's happening there. So there is no certainty around what this looks like, which is why it's so hard to do a talk like this and why I struggled to know what to chat about. I think that we can have these 5 sectors, and I think they can all live in harmony. Adult use, the dispensary model, medical use, find a healthcare involvement, find a way to get a doctor involved, a compounding pharmacy, home health nurses, all these things. Health and wellness, I'm not going to be surprised if we see a nutraceutical version, like if they choose to go this route, this is where they're going to sell their products. But we'll see where hemp-derived products, where THC falls in that health and wellness sphere, or if that needs to be in the medical or adult use. I'm not sure. I think pharma is definitely interested in leveraging phytocannabinoids, synthetic cannabinoids, and other manipulators of the ECS. They're already working on it. They've been working on it for years and years and years. We'll talk about it in a couple slides. But don't think that pharma is going to bow out. But also don't think that pharma wants your adult use cannabis. That's not their game. That's not what they do. That's not their version. This is consumer packaged goods, adult use cannabis, right? And so it'd be more thinking the Walmarts or Walgreens of the world entering that space rather than the pharma companies. Agriculture, so often forgotten, but when they passed the hemp bill in 2014 and 2018, it wasn't supposed to be medicine. It was supposed to be hemp fuel, hemp fiber, hemp clothes, hemp buildings, hemp, all of the industrial part. So I think that there's these 5 sectors that are going to be all working together to create a future that we're looking at. Now, I just want to talk really quickly on the future of regulating drugs. I'm sure I'm out of time. Thank you for your patience, and I appreciate you all hanging. But I want you to see this graph and walk away knowing, hey, what we did here with the war on drugs, it doesn't seem to be working. So this is straight from NIDA, the National Institute on Drug Abuse. This is the drugs that are killing people. There's one winner, especially since 2015 when we cracked down on prescription opioid prescribing. Fentanyl went off the charts. Prescription opioids remain a problem. Psychostimulants, including methamphetamines, but also novel drugs, bath salts, so to speak, are on the rise. Same thing with cocaine, which are both, by the way, associated with psychosis. So that could explain our increase in problem as well. Notice what NIDA doesn't mention in the 23 years of data, single here. Antidepressants get a shout out. They're sitting somewhere around 5,000 deaths a year, a few thousand deaths. Benzodiazepines, a Schedule 4 drug, a schedule lower than marijuana, less restrictive than marijuana, comes in at killing 5 or 10,000 people a year for the last couple decades, maybe one decade. Marijuana doesn't show up. It doesn't even get a shout out. Okay. It's not implicated, which suggests to me that cannabis doesn't belong in these categories, right? How are you going to have a war on a drug that's not even listed here as killing people? It's crazy. A failed war on drugs, just a little bit more. Sorry, this graphic has been copied over from a couple presentations. But look, marijuana continues to be here in 2015, 2016, it's almost a decade ago now, the most common arrest, right? Everyone wants to say, oh, we legalized cannabis. No, we didn't. People are still going to jail. People are still paying fines. People are still getting arrested. People are still getting DUIs. No, we didn't. And we have to keep moving. We have to keep pushing this forward. You would also think, oh, it's better now. 2019, 4 years later, it was still 350,000 on par with the other drugs, right? It's getting better. This is an improvement than this, for sure. We were down from 750 to 350, but 350,000 just 5 years ago. Lots of ways to go. And then the drugs that are killing people, right? Synthetic drugs, they're only a tiny amount of the arrest. So it doesn't make any sense. Another example, again, from the Drug Policy Alliance and the ACLU, arrests are not equal across socioeconomic lines. So per 100,000 people, so per capita, Black people are arrested at a ridiculously higher rate, almost threefold rate higher than white people for marijuana. Possession, right? Not distribution, possession. So why is this happening? Well, they're getting stopped, they're getting frisked, they're getting looked at more, but we still have problems in this data set. I also want to point out, look, it's 2018. A lot of places already legalized. We didn't even have a major improvement between the disparity in arrests between Black and white people for marijuana possession. It's not appropriate. We need to figure that out. 24% of Black people are arrested for marijuana, despite making up almost half of that for the US population. That is an inappropriate disparity that we need to continue to correct. The best way to do that is to legalize marijuana. So, I talked a lot, and now I want to tell you a story. And I know that I'm getting into the weeds a little bit, but I want to tell you a story about a plant that has been used medicinally for millennia. It's called Papaver somniferum, or the opium poppy. Now, it's been used near death, and it's been used throughout history and historical texts. It shows up in modern culture. If you watched Game of Thrones, Milk of Poppy, this is something that's been around forever. And right there in the name, somniferum is derived from the Greek word that ends up meaning sleepiness or somnolence. You can kind of see this, so a bit of a stupor. So this is a sleep-inducing flower with multiple bioactive known as opiates, right? Have you ever heard of a flower filled with multiple bioactives? So identified and isolated morphine in 1823, but didn't commercialize it for another 80 years. So they found a flower. Inside that flower, they found morphine. Morphine becomes common medicine. Opium, the original flower extract. Think of opium as rosin, right? The resins from the opium poppy as opposed to the resins from the cannabis flower. Shortly after, in the 1800s and early 1900s, opium became illegal. And that sort of shifted everything and where we went. Now, importantly, the opium poppy led us to discover endorphins, an endogenous morphine system. Once again, you should be hearing some things should be sounding something like another plant that you're pretty familiar with, okay? The discovery of the endorphins led us to develop new drugs called opioids instead of naturally occurring opiates. Pretty awesome. Lots of medical uses, reduced suffering from pain and surgery globally, but came with a cost, right? Also created an opioid crisis. So, what can we learn from this story of this medicinal plant? Well, what did we do when we made those new synthetics, right? So we discovered the plant back in 1823. We commercialized it in the early 1900s while we made opium illegal, and we started making new drugs. Now, Jim, a lot of people get this wrong, and it's a pet peeve of mine. But you ask people, where does heroin come from? People will immediately respond, poppies, right? The opium poppies. And that is just boldly untrue. In fact, heroin is not naturally occurring at all. Heroin was invented by a pharmaceutical company you still know, the makers of aspirin to this day, which is Bayer Pharmaceuticals. Bayer Pharmaceuticals actually made heroin just a week or two after they made aspirin for the first time. Aspirin is the same story. The bark of the willow tree contains salicylic acid. They acetylated salicylic acid to make aspirin, acetylsalicylic acid. They took morphine, which was found as an opiate in the morphine poppy. They acetylated it and made diacetylmorphine, named it heroin. Pretty cool stuff, but we made it, right? Heroin, this highly addictive drug that's often stigmatized. It's still a Schedule I in the US, remember? That is a pharmaceutical invention. Same thing for oxycodone, which is actually an old invention, 1914. You can see it was available in Percodan a long time ago, since the 1950s. And oxycodone is one of many other semi-synthetics that have been made. just like heroin. They took an opiate from the from the opium poppy, they manipulated it, and they made another drug. Now, in the 1960s, with growing understanding of drugs, we discovered fentanyl, and fentanyl is a super potent opioid agonist that's fully synthetic. It was made by Janssen Pharmaceuticals, a company that still exists today. I think it's owned by um, Johnson and Johnson now. So fentanyl was invented in the 1960s, and then we invented a bunch more drugs. Why am I telling you all of this at the end of a lecture about cannabis? It doesn't make much sense until you think about the story that how we got here, right? How did we get here? We took a drug with many bioactives, isolated what we thought was the ingredient, commercialized that isolate and derivatives of that isolate while outlawing the plant. It helped us discover a system inside of us all, helped many people, but led to a lot of suffering. That's the story I just told you. Here's the story I just built up. You can see fentanyl is extremely potent compared to heroin, and carfentanil, another analog, is extremely even more potent than that. When we develop these potent drugs, we're doing things pharmacologically. I'm going to mostly skip this slide, but know that we develop drugs that do things differently than the natural products, the partial agonists that exist. And as such, they come with more side effects and risk. And in the case of synthetic cannabinoids, we've got a synthetic cannabinoid problem where we're inventing new drugs with relative potencies that are double, hundredfold, thousandfold more potent than the original drug itself, and we can end up with a zombie outbreak. Yes, I said a zombie outbreak because that's what the peer-reviewed literature said about when a synthetic cannabinoid got released onto a product in New York, and everyone outside of that store started walking around looking like a zombie just from a synthetic cannabinoid. And if you look at what's happening with opioids right now, it's not hard to think how this same story could play out. An ancient medicine that's generally accepted throughout time, modernly prohibited plant, inspired pharmacological discoveries with dangerous properties. What happens next if we don't learn from opioids? If we don't learn from the way we treated the opium poppy, what we did to it? What's the next part of cannabis's story if we continue to prohibit it instead of maybe allow its use, propagation, and consumption? I'm not really interested in hearing that, but I don't think it takes your brain very far to jump to where I'm going. And it's just unfortunate that that's where we're at. So there's a lot of stuff out there about legalization. CAOA, deschedules cannabis. We have the MORE Act, which deschedules cannabis. Safe banking, which opens up banking. All of those are fine. I am biased. I'm with Safe Access, and I believe that the Medical Cannabis and Cannabinoid Act is the best move forward. I challenge you to scan this on your screen now. Go ahead and follow the website and read the proposed language by Steph and Americans for Safe Access, and definitely consider your voice with your legislator to be extremely valuable. The Compassionate Pledge says it's basically a super easy tool to use where you can email your legislator and say, hey, you're going to sponsor a reform bill. We need buy-in from legislators about medical cannabis, and this is our push to do that. So please, if you didn't get a chance, scan this, scan the last one, DM me. ASA has been here from the beginning, supporting the same thing that I believe that most of us want, including full decriminalization and a full medicalization, some unity and conformity around legislation and whatnot. So thank you so much for your time. Do me a favor, if you don't already follow me, please do. It's one of the few benefits I get from hanging out here with Jim today. But honestly, thanks for letting me soapbox. I didn't know how that would go. Hopefully you learned something in the process. I see the chat has been quite chatty. So I hope that it's good things. And I'll be happy to field any questions. I know it's late. I haven't looked at the clock. I just know it's late. So if you got to go, don't sweat it.
Thanks so much, Cody. Yeah, the chat's been great. Had a lot of good back and forth on some topics. I did write down some things that I wanted to kind of circle back on. One question from Naima in the chat was, can you speak to talking about like perinatal use or using while pregnant?
Yeah, controversial, right? I think any medicine while pregnant, any medicine should be taken with the extra sense of criticality. I believe that if possible, cannabis should be avoided due to the intrinsic and important nature of the endocannabinoid system during development. However, the flip side to that coin is we know that women are doing it, and we know that we don't have detrimental outcomes by any stretch. There's mixed evidence on what it means, whether there's an effect on the baby, positive or negative. I've recently seen a study positive, but it's a big question mark. And unfortunately, with any medicine and a pregnant woman, it's near impossible to study. Um, so hopefully we'll have a little bit better information over time, but we're never going to have that clear data that sort of pharma demands, so to speak. So I think it always comes down to risk benefit. What benefit is the mother deriving? For what reason are they consuming cannabis? What are the alternatives to that treatment option? Do I think definitively smoking blunts every weekend as a pregnant woman has no effect? No. But do I think that this should be the egregious offense that warrants a CPS interview and all of these crazy things? I don't really believe that either. I think that once again, that's an effective stigmatization, and there are far more harmful things being done to children than perinatal use of marijuana. But once again, as with any patient, but especially a patient who's dealing with something as complex and nuanced as pregnancy, you would want to use the minimum dose possible as infrequently as possible or necessary to optimize your benefits and reduce harms.
And then I think one more that I had, and it was shared by another participant. What about protections for? And I want to preface this with something that I've heard from some of the bureau director who we had on, the Pennsylvania Bureau of Medical Marijuana director, and CANRA, talking about when states make the jump from medical to adult use. It's usually about 25% that the market shrinks. I know that there was some conversation in the chat about kind of patient protections for when that jump happens. But wanted to ask you, Codi, about kind of any strategies that you've seen states take or that you maybe thought about that might be good to help protect the medical population. I know that with that preface, it may be a little bit overstated within kind of cannabis community, but wanted to get your take on that.
I think there's data to support the idea that states who turn on adult use have a decrease in their medical patients. Now, I think there's two things going on there. I think there's some patients who are getting a card who never felt like their use was medical and whatnot. But I also think there's a lot of patients who aren't really seeing the utility in spending the $200, $350 it might cost to continue that legal protection. And so that happens. In fact, I haven't seen a single state that has not happened, a decrease in overall patients. My bigger concern comes with not only a reduction in patient enrollment, which is not my chief concern. My chief concern is making sure the patients that are enrolled are getting the care, help, and services that they need. And I think there's just too many places where that's not happening. So, I'm going to use Virginia as an example because I was just in DC and heard their Department of Cannabis Control speaking. And originally under the Board of Pharmacy as medical cannabis, and then removed from the Board of Pharmacy as they went to adult use and have an overseeing body. Every single year since adult use passed, which is I think just 2 or 3 years now, every single year there's been a proposal to remove pharmacists from the medical dispensary because there is no interest in preserving that model or medical professional from the stakeholders in the industry. So I think one of the biggest challenges we're facing is actually that the cannabis industry is not interested in the medicalization model as much as they are the commercialization model, and that we're seeing a lot of shifts from business strategy to healthcare support in the direction of customers over patients. And I believe that's a shame. American for Safe Access thinks that's a shame because medical got us here. The country wouldn't have bought adult use cannabis if we hadn't have sold them and shown them that everything goes fine and that people aren't losing their shit, they're not going crazy, the kids aren't smoking, the driving isn't out of control. All those things that we need to show and prove, we wouldn't have got here without medical being the proving ground. And I think it's a shame that we would throw the baby out with the bathwater and just say, "Oh, we're ready to commercialize it now."
I did want to ask one final question. Um, I know that you had mentioned Schedule 6 in your presentation, and wanted to see just kind of a brief, where do you currently stand on the best position moving forward about regulating?
Yeah, I mean, so Schedule 6 is within the ASA proposal, the Medical Cannabis and Cannabinoid Act of 2025, I guess is what it'll be before it even gets talked about. I think that is an option. Here's what I guess I wanted everyone to leave this with. I came here with questions, not with answers. So I believe that there is a better way. I believe there's a lot of ways to get there. One way that has been proposed by Steph Scherer of ASA, who I would highly encourage you to have come speak to her own plan, is to create a new schedule, not under FDA, not under DEA, kind of trying to remove some of the challenges that have clearly been brought up by both, right? The DEA being their enforcement agency, not a regulatory agency, so they're not going to be able to help us actually build the thing we need. They can just, hit with a hammer. And then the FDA has openly said they're not the org to do CBD. They don't know hemp. That's not their shtick. So basically no one wants to own this, so we need to own it ourselves, in my opinion. And so I'm of the mindset we need to do something different. Schedule 6 would remove it from FDA and DEA, put it under Health and Human Services. It would create the Office of Medical Cannabis. It would decriminalize completely, expunge all criminal penalties, make a rule that going forward, no more criminalization. One of my biggest fears about this decriminalization movement that we're in right now is that we're going to create a new framework that criminalizes people again. So if you don't play by the new rules, now you're going back to jail for breaking the cannabis laws. And that cannot be what we do. That is an extension of the drug war rather than an abolishment of it, particularly the war on cannabis. So that's another thing that I'm really skeptical of. I believe it's the MORE Act does this. It reestablishes the rules, but then creates penalties that are criminal if you break those new rules. So it's just an extension, in my opinion. So that's a big thing I think we need to focus on is full decriminalization, which is what everyone wants. We need to protect medical patients' rights, right? Their ability to consume cannabis in their apartment building in the state of Georgia. I think I just saw a wonderful comment mentioning that, disparities and racial disparities continue to be a problem in those places. People, fair access to housing, using your housing credits, right? Could you have those removed? Getting your college funded because you're a medical cannabis patient, but you got caught with weed, busted for a marijuana offense. All these still matter. We haven't solved them yet. And we got to keep track of it. One answer is Schedule 6 for Americans for safe access. There are many other answers, but the most important thing that I think I can implore everyone listening today to do is just tell your representative you care. For me, specifically, you care about medical cannabis, but maybe you also care about social equity. Maybe you really care about expungement or what I talked on the criminalization. Tell them you care about this issue because as of right now, our representatives, and I mean this as someone who was just in DC, just talking to numerous representatives, and the first question they have is like, what's your problem? Like, I thought everyone has access to cannabis. And the truth is there is a gross disparity and misunderstandings because it's so complicated that everyone thinks people are going to get what they need in adult use or people are going to get what they need in hemp. But the truth is it's getting really complicated and it's hard for patients. And I don't want to forget about them in the process.
Thank you, Codi, for all of that information and definitely some great perspective. And I continue to learn with each and every post that you have and look forward to continuing following your work and definitely recommend following Codi on his socials, especially LinkedIn. I think it's a good way to kind of keep up with what's going on within the industry in general. And thank you to everyone who attended. Hope to see you guys in a future speaker series. Our next one will be on November 18th